I'm here in studio with Dr. Christopher Lathan, Chief Clinical Access and Equity Officer at the Dana-Farber Cancer Institute, and an oncologist who focuses on patients with lung cancer. Dr. Lathan, thank you so much for being here today and joining us. So please share with us, what led you to your career as a lung oncologist?
Yeah, thanks for having me. So I grew up in Springfield, Mass, and I liked science, but I had never really worked with physicians. And after I went to college, I really had some people who really invested in me and suggested a lot of things for me. They were mostly wrong, but one person did say to me, you should think about going into medicine. And I had never really thought about it. And I was fortunate enough to work for a little while, worked in the laboratory, and one of the laboratory folks really said this could be a career for me, and that's how I chose it.
Wow. Could you please share with us the causes and risk factors for breast cancer?
The number one risk for cancer, it tends to be age. So one of the major risk factors is age. Certainly being a woman is another risk factor. And then you start to look at what I call the modifiable things. We always wonder the things that we're doing to our body that could cause cancer. So we see that increased weight after 18 can actually be a risk for cancer, and we think that's one of the reasons that breast cancer risk is increasing. There's some data that talks a little bit about alcohol intake as well, impacting that. And those are some of those modifiable risk factors. But when you think about the other things, the genetics, so a family history, there's some people who might have a specific family of genes, the BRCA genes you hear people talk about. And so sometimes that actually is a risk factor. So you take the age, you take hormone and hormone replacement, those are other risk factors, and then you add in a history and family medical history. Those all mix together to possibly cause breast cancer. So there's not one cause, but all of those things could together cause breast cancer in folks.
Tell us, why is it important for people to sort of peel away the fear factor around cancer and get the information that they need to better understand how to prevent or treat cancer?
Yeah, so it's a great question, because I think especially for our communities and for our marginalized communities, sometimes the fear of the cancer diagnosis can keep us from getting to the care that's right here at our front door. So it's really important when you look at your family history and you think about folks who had cancer, especially earlier than 50. Because as I mentioned, age is a risk factor, but certainly anybody before 50, when you have a cancer before 50, that should be the first flag that if your first degree relative, your mother, or your brother, or your sister, or your father, if any of those folks had cancer before 50, that could be a sign. It's not a definite sign. It could be a sign that there is some cancer risk in your family. And so we have geneticists who work in our clinics, and they can say if you have a history of breast cancer in your family and you have multiple relatives that have early breast cancer, that's a good time to have a conversation with your PCP and say, hey, I might need to talk to somebody because there could be some risk here. And it could even impact when you might want to do screening. But that's really why it's important to not necessarily be afraid to have those conversations with your family members, because folks sometimes don't want to talk about the cancer. A lot of folks if they dealt with their cancer, they moved on, that was in the past, and I'm going on with my life. So sometimes you got to push family and say, hey, did I hear this is what happened to Auntie? This is what happened, and tell me how old were you when you had it, and that can help you with your own risk.
I agree, as I've experienced cancer with both of my parents, and although it's scary, the conversations are really great to just be able to break the ice and making sure that everybody stays safe and healthy. Can you share with us in your treatment and your practice, is cancer on the incline?
The short answer to that is it depends on what type of cancer it is. But let's talk a little bit about breast cancer, and then I can talk about the cancer that I treat a lot of, lung cancer. So, for example, the diagnosis of breast cancer is on the incline a little bit. It's been about half a percentage point each year since the late 80s. The good news is the mortality or death rate for breast cancer has been going down, and part of that is due to all the great treatments that people have, and we have utilizing the screening. For lung cancer, for example, both the incidence, the number of cases are going down, and also the mortality rate is decreasing slightly too. And so I think each cancer is different. We do know that some cancers are on the rise in young people, like colorectal cancer, which we don't have a good answer for. We're seeing a higher incidence of colorectal cancer. So some cancers are coming down, And some other cancers are coming up a little bit. As I mentioned, breast cancer, maybe the diagnoses coming up just a slight bit each year. And then it could be related to, as I mentioned, weight is a risk factor. And so as our society as a whole, as we all have more issues with weight and weight gain, that could be impacting the diagnoses. At least we know with breast cancer, the mortality rate or the death rate is going down a little bit.
And Dr. Lathan, share with us, how does a person's quality of life affect their likelihood of getting or preventing cancer?
This is a great question, and it's complicated, right? Because we really think about how our risk and how our past history impacts our present. So let me give you an example. So let's talk about lung cancer, where we talk about tobacco as a risk factor. Well, what we know is that folks who have less than a high school education, we know that if you have less financial resources, you're going to be more likely to smoke. And we also know that in folks in marginalized communities and with the food islands are less likely to be able to have a nutritious diet that's really going to be healthy for them. So you're going to see vulnerable communities from the start at risk, right, because of the stress. We're not even talking about environmental risk yet. And then the types of jobs that you have make it very difficult for you to even do the screening. So if you're working hourly, how do you go to see your PCP and all of that? So when people think about stress causing cancer, they're thinking about it as in, I'm stressed and it's making a tumor grow. But if you really look at life stress and access to healthy activities, that actually can contribute to it. And then you have to be able to go see your physician and experience trust and talk to them. So I think all of those things are what put many of our communities and our working poor communities at risk. It's an accumulation of stress. And then there is some data that shows that there's some environmental causes. If you think about pollution and different toxins and PFAS and all these other things that we see are in the environment that are in our food system, they probably are contributing a little bit as well.
Do certain neighborhoods stand out for having higher rates of different types of cancer? To add on to that, what treatment is available for patients living in these neighborhoods?
So we know a couple of things in Boston. So there's some good news in that Massachusetts in general has some lower cancer rates compared to other states. But as we look into our own state, even in this supposed good news, we see that individual communities of color are at higher risk. And actually there's some rural communities, and this is a surprise to some folks. You think, are there rural communities in Massachusetts? But there are. They have some cancer risk as well, kind of elevated cancer risk. So when we, and some folks, if you look at liver cancer, right, is one of the cancers in Massachusetts that's slightly increasing. We talked a little bit about colorectal cancer, and we're seeing those incidences higher in our Black and brown communities and in our working poor communities. And that's where we see an increase in most of the cancer types. As far as lung cancer, again, looking where smoking is, same sort of things. If you're looking at working poor communities, you're going to see a higher increase of tobacco exposure, and you're seeing slightly higher rates of lung cancer there. And then there's some rural communities and some communities on the Cape, ironically, where we're seeing some slightly higher cancer incidences. So we see some trends that are true all the way through the country in Massachusetts, where our immigrant communities and our Black and brown communities and our working poor communities have higher risk. But then there's some unique features of Massachusetts where we're seeing higher risk in some of these rural areas as well.
Dr. Lathan, I would love to share with the community and with Boston the amazing work and the special impact projects that you're doing. Please share with us the work you're doing with Dana-Farber Cancer Institute and the importance behind it.
That really came from the idea that when I came to the Dana-Farber, I was struck by there's all this great care, really defining new areas of treatment, and that's really exciting. But I noticed that even though the Farber was right in the middle of the city, that there were, folks that were just, across Huntington away, and they weren't really feeling that hospital was their hospital. And then when I went into communities, people would say, well, that hospital's not for me. And then I did some back information and saying, well, the insurance are taken, and so it was really a feeling that and I wanted to make sure that we opened the doors, more than just saying the doors are open, but actually going into communities and demonstrating that the doors are open. And really, if we found some barriers, I also felt that when folks come in to see their primary care clinicians, primary care docs are very busy, they're doing lots of work, and if we could take some of that load off of them around cancer and if we could be in the community, and that's what we decided to do, go into the center and say, hey, if you have any cancer-related question, refer to us. We'll work it up. And hopefully the person doesn't have a cancer-related question and nobody has to leave their community health center. But for people who do, we kind of expedite that pathway and then we make a diagnosis. And we've been doing that work for about 12 years. And we find that there's some benefits. You know, people seem to, we wanted to decrease the amount of time it took folks to get their diagnosis, and we were able to show that. And then we find that when people do come to the cancer center, they seem to be slightly more likely to be on clinical trials. And I think that really has to do with trust more than anything else. So that was really important because the treatment for cancer has changed so much. I've been an oncologist for 20 years, and I would say that when I first started my training, we just had chemo. And you know, chemotherapy just destroying cells that are growing fast and the side effects that come with that. And now the tools that we have, how we treat your cancer depends on its genetic marker, the receptors that it expresses. We have ways to, you know, immunotherapy, which is help your immune system fight the cancer. We have many different targeted treatments. And so while we still have a long way to go, we have so many therapies. And so I want our folks to be able to have access to all those therapies. I always say, just like if you're in Wellesley, your zip code shouldn't matter. Right? Whatever your zip code is, you should be able to get the same care. And that's why we set up our programs.
Absolutely. I love to hear that, you know, in Dana-Farber being a nationally renowned institute, that a lot of residents who are experiencing living with cancer less than a mile away from the institute don't access it, and quite frankly just don't know how to ask, and to your point, have this stigma and fear that that place isn't for me, that hospital isn't for me. So I love hearing that you're working with community health centers to help do that integrative approach and go and meet people where they're at. So thank you for your work on that. Our Health of Boston reports have found higher cancer mortality rate among Black and Brown residents in Boston. Why is this? And what inequities among patients have you seen during your time as an oncologist?
Yeah, so this is really where I've spent most of my career, trying to first describe these disparities and now trying to rectify them. So I think many people like to think, so the first question is like, well, is this just something different about folks? There's higher cancer related, you know, in this group or that group. And what we know for the most part, most of the differences that we're seeing, these racial differences, have nothing to do with the genetics. And you know, I'll come back to this because people say, what do you mean? Are you sure about that? I'm not saying 100% is not, but generally there is no difference. Like race is a social construct, right? So there's ancestry, there's, you know, we talked about before, your family history and where your ancestors came from, and we try to use race as a shortcut for that. If you look at people, we say, I think I know where you're from. And that's why people thought, well, this group has a higher incidence of cancer. It's more complicated than that. It's really about what's your risk, as you heard me say before, the risks, you know, what kind of food are you able to get to, what kind of job do you have that puts you at risk. We know that our Black and Brown communities are less likely to be able to have access to primary care, which makes them less likely to be diagnosed at the same time as, you know, their other counterparts who might have more resources. So there's your first hit right there, is that even if you do have problems, you're going to get diagnosed later. Also, you have a job that might not let you take time off. So even if you have symptoms, maybe you're not able to go until your disease is at a later stage. So we know that Black and Brown communities get diagnosed at later stage. They are less likely to be able to access their care. And then even when they do access their care, they're less likely to be able to get the high level care that other folks do. And again, is that insurance? Is that, you know, racism, systemic and individual? Yes. Is it a combination of a lack of resources that allow people to come into the cancer center? Yes, it is all those things adding up. The thing that we know that we can do to fix that, though, is we have to attack all of those different things. We have to make sure that people can get a ride to come in. We have to make sure that we're reaching out to communities and show them that screening matters. Why do we trust that screening helps? People say, I don't want to know.
Right.
But we have to empower folks to let them know that we can make a difference, and we can push your clinicians, hey, you need to have a conversation about prostate cancer with your primary care doc. And if that person's not doing it for you or explaining it, let's go somewhere else. And then we have to improve the whole infrastructure. So the short answer is yes, there are differences. Most of those differences, 70%, have to do with our infrastructure and our barriers and the systemic barriers. Probably about 30%, and that's probably in the gender-specific cancers, prostate cancer and breast cancer, are a little more ancestral, and they have linked to that. But everything else is probably barriers from the way our society is put together.
Thank you for highlighting that for us. It's just really amazing and beautiful to see a doctor who identifies as African American in this space. As many people know, that when you are able to be in a space where you're working with somebody, whether they're your teacher or you're somebody who you report to at work, or your primary care physician or your oncologist, that it really does make a difference in the way that you feel empowered, the way that you want to receive treatment, and your motivation to be connected to that space when you're able to identify with the person who is sort of in that authoritative role. Can you explain in detail the stages of cancer and how that impacts people?
Yeah, so this is really one of the most important things when people come into my office to see me. The first thing I ask myself is, what type of cancer is it? Because cancer is very, very different. I have to identify it. And then stage really tells us the question, where is it? How big is it? And so the easiest way to look at this is a stage 1 cancer is very local. And generally, it's different in every disease, so I can't speak too specifically, but it is very local and it hasn't spread any place. It's really in one spot. A stage 2 is probably maybe a little bit bigger, maybe just spread regionally, but it's still localized. When you get to stage 3, then the cancer has spread a little bit further. It hasn't, spread all the way through the body, but it might be harder to take care of with surgery or with a local treatment. And when people hear stage 4 metastatic, that means the cancer has gone through the bloodstream and it's in different places, and you can't remove it with a local treatment. And that's when you have to use things like chemotherapy or immunotherapy to try to control the cancer. So early stage cancers we treat and are easier to cure. Later stage cancers are harder to cure locally, and we tend to start using that IV therapies and pills to deliver treatment all the way through the body.
Thank you. And I know oftentimes the treatment of those things can feel very daunting, as it can be taxing on the body. Can you just sort of share some of those side effects and other treatments that are available to help people combat those side effects?
Yeah, so when I first started, we only had chemotherapy, and people think about chemotherapy. That's where we're giving treatments, usually IV, although there are some chemotherapy pills as well that were causing the cancer cells to kill the cancer cells that are the cells that are growing very fast. And that's, you get side effects like nausea. Sometimes you have hair loss. Again, depends on the chemotherapy and depends on the cancer. What we have now, and there are treatments that we have for nausea and for some of the side effects. I think in the early 80s and 90s, before some of that, treatment was very difficult to withstand. We have anti-nausea medication that's very powerful that can get people through. We also have medications that can help with things like, putting people at risk for infection with low white counts. But we also now have new therapies that don't necessarily impact the body in the same way. There are different side effects. So there might be targeted therapies where you can take a pill for lung cancer, for example, and you don't lose your hair. You might have a rash. You might have some other side effects, but the side effects are nowhere near as bad as chemo, and it can be just as effective. Or immunotherapy, where we're trying to use the body's immune system to fight the cancer. And again, there are some side effects, but they're not as bad as the side effects for traditional chemotherapy. So now we have all these different tools. Each one of them has different side effects, but more and more we're being able to deliver the care without causing you as much harm, and that's the goal.
And Dr. Lathan, share with us, how can Boston residents prevent cancer?
So what we are seeing and what we think could be contributing to some of the new, the increase in cancer is the fact that we know that with increasing weight for folks, we're seeing that they are higher risk for cancers. And the most direct way to think about this is colorectal cancer, but we see this also in breast cancer and other cancers as well, where it's probably a additive effect. Perhaps it's fat intake for food. We know in colorectal cancer you have red meat, but there's something about we're seeing even something else for liver cancer where the increased weight seems to have a direct impact on the incidence of cancer. And we don't know exactly how. in some cases, but we're definitely seeing that in many different cancers. So it's a major issue. And again, as we talked about for our communities, if you are in a food island and nutritious food costs a lot more, and then it's really hard to think about how we can work on on weight. And I want to just add this, as you think about some of the new treatments for weight that they're out there, a lot of our communities are wondering if it's good for them. So here's the thing: if you can get the weight down, it seems to be decreasing the risk for cardiac disease, yes, and all these other things, but we're hopeful too that you might see a lower risk.
Thank you so much, Dr. Lathan. Are there any closing thoughts or statement you'd like to make?
I think what I would like to say to people is that there are opportunities out there. One is have conversations with your doctors, and really be honest with them and push them if you don't feel like you have a good connection, because sometimes there's another person who can really connect with you and make sure you're getting the conversation that you need, and go to your screenings. And then I want to make one comment about clinical trials, because in oncology cancer, in oncology treatment, clinical trials are a big part of what we do. And this is something people think about for experimental care. You don't have to be on a clinical trial, but I want to say that every oncology therapy we had started as a clinical trial. And this is our communities of color are underrepresented. So we are not in these new therapies as they're being developed. So then we don't really get to be a part of the conversation as they get rolled out into communities. And also they're not really tested on our communities. So I always tell folks, ask questions. If people want to talk to you about a clinical trial, it's okay to listen. Talking never hurt anybody. You can always say no, and then ask questions for other folks. And I have people, I say bring everybody in. There's always somebody who's making decisions. So if it's the spouse, if it's a sister or a cousin or a minister, come on in. We'll have conversations about trials, because sometimes that's going to be the best treatment for you, and you want to be able to make that decision.
Dr. Lathan, thank you so much for being here today.
Thanks for having me.